Hi, and thank you for listening to this paper talk. I'm Karthik Bhat, a PhD student at Georgia Tech, and I'm presenting the paper titled Infrastructuring Telehealth in Informal Patient-Doctor Contexts. I co-authored this paper with Dr. Mohit Jain from Microsoft Research India and Dr. Neha Kumar at Georgia Tech. I'll start off with a quick background on telehealth and its adoption in India. At its inception, telehealth was seen as a crucial addition to healthcare infrastructures around the world. It promised quality care delivery to remote regions of different countries and reduced expenses of care seeking and provision, among many other benefits. India's healthcare system is known to be under-resourced. A large majority of the private and public healthcare infrastructure is located in urban regions, with few hospitals in more rural regions. It was in this context that telehealth adoption showed initial promise in India by bringing better quality healthcare closer to the more rural regions of the country. In practice, this took the form of multiple private and public hospitals establishing telemedicine departments to afford communication and consultations between their doctors and the local doctors in rural regions. Primarily, these facilities served as convenient follow-up mechanisms, as well as initial screening consultations to assess whether a patient needed specialized care at a more urban, better resourced hospital. The onset of the COVID-19 pandemic drastically disrupted this system. Lockdowns enforced by the Indian government meant that patients who needed healthcare for non-COVID conditions were severely impacted. In response, India introduced the telemedicine practice guidelines in March 2020 that really loosened previously strict regulations on how telemedicine could be practiced. This allowed for doctors to prescribe medicines directly to patients via telemedicine, to provide remote diagnosis, and for doctors to use any platform they wish to conduct these consultations. This would have significantly reduced burdens on patients and doctors to continue care practices during the pandemic. We recognized, however, that access did not necessarily translate to usage or good experiences during teleconsultations. So we asked, how are patients and doctors adapting to shifting trends in healthcare provision in response to COVID-19? We addressed our research questions by conducting a survey and interview study in July and August 2020, a few months into the pandemic and about 3 months after the first government measures to restrict the spread of COVID-19. We broadly disseminated a survey to participants living in India and who had visited a doctor within the past year, either in person or remotely. This survey asked people's expectations around telehealth, frequency of teleconsultations, and experiences with telehealth prior to the pandemic. In total, we received 181 survey responses, with 58 being from doctors and 123 from patients, primarily from urban regions of India. Next, we conducted 18 semi-structured interviews with patients and doctors in August 2020 to ask about their experiences with remote care and expectations they had for the future. These were conducted remotely via WhatsApp and BlueJeans, given the timing that was conducted in. In analyzing our findings, we built on STAR's seminal work on infrastructures to understand how breakdowns in healthcare infrastructures during the pandemic could shed light on its underlying components. Then we focused on how the different stakeholders were involved in infrastructuring work, both in maintaining the healthcare infrastructures pre-pandemic and in creating new telehealth infrastructures during this transition. Our findings are divided into 3 major themes around how care provision behaviors are changing as a result of COVID-19. They are shifting technologies and adopting telehealth, shifting expectations of patient-doctor consultations, and shifting dynamics of caregiving. For time constraint, I will keep our findings short. Please read our paper for more detailed findings. WhatsApp use is widespread in India, and when lockdowns and other COVID-19 prevention measures made routine patient-doctor consultations more difficult, WhatsApp immediately filled these gaps. Its features for sharing PDFs, images, and so on allowed for easy medical data sharing between patients and doctors to make these consultations happen. We know that many doctors point out how some of these practices, like phone and WhatsApp-based follow-ups, existed long before the pandemic, just that at the time it was informal and restricted to a subset of use cases, with all diagnostic consultations still being in person. To us, this practice brought up issues of data privacy and management, given WhatsApp also served as a personal communication tool, which potentially had semi-private or shared usage within households. When asked about it, our participants explained that for them, seeking care itself was far more important than the potential dangers of a loss of privacy around this data. They also explained that they trusted their doctors to deal with their data appropriately. Finally, coming to the tech-based challenges with remote care, we found that they stem from bad video quality during consultations and a lack of know-how on behalf of the patients and their caregivers to facilitate effective remote consultations. Respecting time constraints, I will not be reading out these quotes, but I encourage you to pause the video to read them if you're interested. Our next finding was around the shifting expectations of patient-doctor exchanges. Doctors noted that they were primarily trained to treat patients in person, and a sudden switch to telehealth meant that they had to adopt new diagnostic practices just to continue providing care to their patients. At the time, this meant an increased focus on patient history, despite the risk of missed or misrepresented symptoms. None of the doctors we interviewed indicated that they had found a satisfactory mechanism to provide remote care. Switching to telehealth also meant that doctors could not sufficiently invest in building a rapport with their patients, something that they regularly did during physical consultations. They said this made healthcare more transactional and less relational, going at odds with their regular practice. This transactionality not only affected the experience of consultations, but also the very literal transactions of payment for consultations. Previously, for in-person interactions, the expectation of payment was implicit in the visit. With a complete switch to teleconsultations, doctors described a sense of awkwardness at revamping the system and asking patients directly for payments for their services. Finally, given that doctors were available on their personal phones for teleconsultations, this gave the impression to patients of their 24/7 availability for consultations. With fewer logistical barriers like travel time, waiting time, and clinic hours, patients lauded the benefits of having a doctor able to treat them during their free time as a benefit of remote care. Again, I will be skipping this quote, but please feel free to pause and read how a participant described an experience with a bad experience with a remote consultation. Our final finding was on the shifting dynamics of caregiving among the various stakeholders in care provision. Doctors noted how family-doctor relationships, where a particular doctor treats multiple generations of a household, were becoming harder to create and nurture with teleconsultations. Next, pharmacists had particularly greater decision-making roles, given that the government regulations around telemedicine prescriptions were in flux and constantly changing, either permitting or not permitting certain forms of prescriptions. And finally, clinic support staff roles became redundant as their responsibilities were distributed among doctors, patients, and family caregivers in their one-to-one interactions via WhatsApp or the many other mechanisms that they used. We go into a lot more detail into these findings in our paper. Quickly moving to our discussion, our findings highlighted doctors' shift in priorities and practices when they transitioned to teleconsultations. In particular, many of the activities that constitute teleconsultations were actually being practiced informally, even before the pandemic. A transition to making telehealth more mainstream meant that there was an overlap of these formal and informal interactions between patients and doctors. This needed both parties to create new telehealth infrastructures so that informality could coexist with the more transactional, formal patient-doctor interactions. The transition to telehealth also made social and emotional burdens on doctors worse by the virtue of the additional work they needed to do just to continue providing care to their patients and prevent further breakdowns of healthcare infrastructures. Next, our patients found the shift largely a positive experience, though with some caveats that we described earlier. It worked towards rebalancing power in patient-doctor interactions, especially as patients had more agency and involvement in their own care process, right from choosing doctors online to how they interacted in consultations. This extends ongoing conversations in CSCW and CHI around how the changing dynamics of patient-doctor interactions in India because of new access to information. For other stakeholders like clinical assistants and support staff, it brings up questions of what roles they will play in the future of telehealth work. Our findings showed how these roles are becoming redundant and being distributed among other stakeholders, with most of the clinical responsibility falling on patients and their caregivers. Next, we found that doctors pieced together a wide range of existing technologies to emulate the infrastructures of in-person consultations. Many of these mechanisms made implicit assumptions about the technology literacy of users, including things as fundamental as possessing email IDs that they had sole access to. We argue that future telehealth systems must not put the burden of technology proficiency on the patients and instead predominantly leverage widely used technologies in the region, like WhatsApp and mobile wallets in India, to ensure that their service is not restricted only to the technologically savvy. On a related note, an approach to addressing the problem of awkwardness around payments could incorporate digital payment queues from a variety of e-commerce platforms in India that require prior payment for services built into the platform, with the ability to reverse transactions where necessary. This would allow doctors to take charge of what services they choose to receive payment for, and remove some of the awkwardness that they found in directly asking patients for payment. Finally, our findings brought up an intriguing distinction between how physical and digital health data was managed. While physical health data, like medical reports and prescriptions, were safeguarded at home to restrict unauthorized access and use, similar practices did not translate to digital spaces except in very specific cases. Future design of telehealth systems then could incorporate mechanisms for short-term sharing of images and videos. This would not only afford effective patients' health data management, but also ensure that doctors' personal devices were not being overloaded with patient data. As a research direction also, we found a paucity of work in HCI on health data and situated privacy considerations in India, especially as India recently, as of September 2021, introduced a large-scale digital health data standard. Research into these situated privacy practices could provide crucial insights and design considerations for its rollout. Thank you so much for listening to my talk. If you'd like to get in touch to talk about the paper more or talk about ideas or collaborations, please reach out to me in any of these ways.